talented and dedicated alumnus, Dr. Jansi, consultant radiologist at Narvi Hospitals, Vellore. She has contributed cases for the book Imaging in Tuberculosis, Best Scientific Paper Award at Sonu Summit, Yuva Awas Paper at IRIA 73rd Annual Conference.
A warm good evening to one and all present here. First, I would like to thank my professor and head of the department, Dr. Devi Meenal ma'am, for providing this great opportunity. And I would like to extend my thanks to our professor, Dr. Gopinathan sir, all other associate professors, assistant professors, and my dear colleagues. So we'll move to the cases. So this is the first case. Here we can see that there are T1 hyperintense areas in bilateral adnexal cyst, and these corresponding areas show hemosiderin staining with which corresponds to some old chronic blood products with T2 shading sign. So what could be the probable diagnosis? So it's a case of an endometriotic cyst. Here we can see that there are adhesions noted with the anterior wall of the rectosigmoid. So in this case, we should suspect deep pelvic endometriosis. And what do you mean by the term catamenial pneumothorax? So catamenial pneumothorax is nothing but because of the endometriotic deposit in the diaphragm, the patient may have multiple episodes of recurrent spontaneous pneumothorax during menstruation. So these are all the common sites for the endometriotic deposits like vesico-uterine pouch and the vesico-vaginal septum and the recto-uterine pouch, recto-vaginal pouch or the recto-vaginal septum. And one more thing is that it is not necessary to have hemorrhagic cyst to diagnose endometriosis. Sometimes blood-filled fallopian tubes or maybe the only finding to suspect endometriosis. So if we see hematosalpinx, so first thing to be kept in mind is endometriosis. Do they develop CA? Is there any chances for the endometriotic women to develop CA? Yes, there are chances. It is about 2.5% of the women with endometriosis may develop ovarian carcinoma, most likely the clear cell and the endometrioid subtypes. So in the first image, we can see the endometriotic deposit in the vesico-uterine pouch, and here we can see the adhesions with the anterior wall of the rectum. In the third image, we can see there is thickened uterosacral ligament on the right side. In the fourth image, there is thickening of the round ligament. All these findings are commonly seen in the deep pelvic endometriosis. And this fifth image is an interesting image. It is because this young lady presented with sudden onset of right lower limb pain. She went to multiple hospitals, but they couldn't find the exact cause, and it was later found to be an endometriotic deposit in the right sciatic nerve at the level of the greater sciatic foramen. So it is a case of sciatic nerve endometriosis. So two new things about endometriotic cysts. So one is it is a known thing only, like it shows diffusion restriction. So it is a common thought that whatever cyst which shows diffusion restriction may be a neoplastic lesion. So this endometriotic cyst usually show diffusion restriction because of the T2 blackout effects. And a new term which is a decidualized endometriosis. So which is nothing but in pregnant females, because of the increased level of progesterone, this progesterone acts on the endometrial stromal cells, so which causes decidualization. So in between the endometriotic deposits, there are T2 hyperintense areas which shows the decidualized endometriosis. So this is intrauterine fetus and multiple endometriotic deposits. In between them, there are decidualized endometriosis, and this is a focal uterine contraction. So moving to case number 2, this is also an interesting case. This 55-year-old lady with a history of hysterectomy for the fibroids. She presented with abdominal swelling a few years later. So what will be the probable diagnosis? If a patient with old history of hysterectomy for fibroid and presenting again with the abdominal swelling or an intraperitoneal swelling, an entity known as benign metastatizing leiomyoma, which is also known as disseminated peritoneal leiomyomatosis, should be kept in mind. It is not only that these leiomyomas may metastatize to the peritoneal cavity, it may metastatize to the lung. The same patient showed a well-defined nodule in the right lung, so which is a benign metastatizing leiomyoma of the lung. So this patient, they have done biopsy of this abdominal wall swelling, which turned out to have a malignant component. So this was turned out to be a metastatic leiomyosarcoma. Not only this peritoneal cavity, it may gain access to any place. So basic theory is that it gains access through the pelvic venous channels and reaches every other place. So this is a case in which there is an intracaval leiomyoma, and there are parametrial deposits of leiomyoma, deposits of leiomyoma in the parametrial veins. One another similar condition, whereas we can see the same entity of the benign metastatizing type, it can be seen in the neck, that is the pleomorphic adenoma of the parotid. In pleomorphic adenoma also there can be a benign metastasis to lung, bone or soft tissues. This case number 3. So there are 4 different cases of HSG. So in the image A, we can see there are multiple irregular filling defects within the uterine cavity. She gives the history of multiple DNCs in the past. So these could represent the intrauterine adhesions which is seen in the Asherman syndrome. In the image B, we can see that on the right side, the isthmic portion of the fallopian tube is involved and there are areas of pseudo-diverticulosis. It is a condition named salpingitis isthmica nodosa. So here what happens is that there will be inflammation of the fallopian tube and there will be pseudo-diverticulosis formation. This condition especially involves the isthmic segment. So it is referred to as salpingitis isthmica nodosa. And in the third image, we can see that there is bilateral irregular narrowing of the fallopian tubes. This could probably due to fibrosis and strictures commonly seen in genital tuberculosis. And the fourth condition, this is bilateral tortuous dilated fallopian tubes, hydrosalpinx. So first one is the Asherman's. Typically that female will give the history of multiple DNCs. And the second image is the salpingitis isthmica nodosa. Third one is the genital TB. Fourth is the hydrosalpinx. Case number 4. If we see solid lesions in bilateral ovaries, first differential should be ovarian metastasis, especially the Krukenberg's metastasis. So we should search for the primary. The most common primary site is the pylorus of the stomach. The next common sites include colon, appendicular CA or breast cancer, especially invasive lobular carcinoma. And the one important thing with this Krukenberg's tumors are that they are almost always signet ring cells. So only the signet ring carcinoma of the pylorus metastatize to the ovaries. Even the non-signet ring cells also metastatize to ovaries, but they are not called as Krukenberg's tumors. Only those tumors having signet ring morphology are called as Krukenberg's tumors. If it is non-signet ring morphology, then it is called as non-Krukenberg's metastasis, like in malignant melanoma. In such case, we may see areas of T1 hyperintensity in the ovary because of the presence of melanin cells. Why is the age predilection 45 years for Krukenberg's metastasis? It is because the pyloric carcinoma occurs around the age of 40 to 45 years, and so the corresponding metastasis to ovary occurs at 45 years. But it may take several months to even 10 years for the metastasis to occur. This is a straightforward case. Here we are seeing the echogenic floating content, which is the fat. So fat fluid level is seen with hyperechoic floating nodule with hairy appearance. So one sign is the fat fluid sign, next one is the Rokitansky nodule, and here we are seeing the dot dash appearance. So this kind of floating ball sign, tip of the iceberg sign, or a fat fluid sign, Rokitansky nodule, all favors dermoid cyst. Corresponding MRI images, T1 and T2 hyperintense nodule, which shows suppression in the T1 FS sequence. So this nodule is suppressed in the fat suppression sequences. So it is diagnostic of a mature cystic teratoma or a dermoid cyst. So anything which appears bright in T1 can be hemorrhage or fat. So the main sequence to differentiate an endometriotic cyst from a dermoid cyst is T1FS sequence. Its malignant counterpart is immature teratoma. So this is how the dermoid plug appears. So this hairy things are seen in the images as dot dash sign and floating ball sign. But it is very common to miss this kind of echogenic dermoid. If the cystic component is very less, it is common to miss in the ultrasound because we may mistake it to be fecal material or fecal filled bowel. So again, case number 6, this is a well-defined cyst seen in the posterior aspect of the vagina. This is pubic symphysis. It is seen below the level of the pubic symphysis and posterior aspect of the vagina. This is a Bartholin cyst. The commonest location is it is below the pubic symphysis in the posterior aspect. Commonest complication is the secondary infection. So Bartholin gland abscess. Differentials include Gartner's duct cyst. This is a Gartner's duct cyst. It is seen at or above the level of the pubic symphysis. And the next common differential is a paraurethral cyst or a Skeen's duct cyst. It is seen in at the level of the external urethral meatus. And case number 7. Here we are seeing a T1 hypointense, T2 hyperintense bilateral multiloculated adnexal masses. And these content of the mass is showing diffusion restriction. So it is not T1 hyperintense. So the inside content is not blood, it is not fat. So there is something else which shows diffusion restriction. So it is a thick pus. So we gave the diagnosis as bilateral tubo-ovarian abscess. It is because the patient also presented with lower abdominal pain and fever. So it's a case of bilateral tubo-ovarian abscess, and in the intra-op they have drained around 300 to 500 ml of pus, and the organism was found to be Escherichia coli. This is again an interesting case. It's a 26-year-old female. She presented with right-sided gluteal abscess and a draining sinus. And initially X-ray was taken. It showed multiple long fetal bones in the pelvis on either side. Then there is a CT image. It shows predominantly fat-containing lesion with long fetal bones. Here we can see long bones. Here we can see long bones in the peritoneal cavity within the predominantly fat-containing lesion. Here you can see the gluteal abscess on the right side with a draining sinus. And even the MRI images show the same T1, T2 hyperintensity fat content. It is suppressed in T1FS. It is located in the presacral location. So we gave two differentials, like it could be a mature teratoma, or as we see the long bones, the close differential could be fetus in situ. So what is fetus in situ? It occurs in diamniotic monochorionic pregnancies. So to diagnose fetus in situ, we should see any one of the three, like at least we have to see the axial skeleton or long bones or any body parts. It is nothing but in a twin pregnancy, what happens is that one non-viable fetus will present inside another viable fetal abdomen. So which is referred to as fetus in situ. So the large fat containing lesion was removed, and the pathology came out like this. Like they also they were in confusion to give it as a mature cystic teratoma or a fetus in situ. They all come under the same spectrum. Though axial skeleton is not visualized, but the presence of long bones highly suggestive of a fetus in situ. So this is one another similar case. This case we saw in KMC during our PG period. This 26-year-old lady, she came with lower abdominal pain and 6 to 7 months of amenorrhea. On imaging, it was found to be a dead fetus within the intrauterine cavity, which is all calcified, mummified, and the immune system considered this dead fetus as a foreign body and covers it with calciferous substance. So this condition is known as lithopedion, And this is an intra-op image showing multiple fetal bony parts within the uterine cavity. Later on, she presented with cervicocutaneous fistula, which we demonstrated by injecting contrast through the skin. The contrast reached the cervix. So it's a cervicocutaneous fistula. Case number 9. This lady UPT positive, but the endometrial cavity is empty, and there is a left adnexal lesion. Is the tubal reaction showing tubal ring sign, Bagel sign, blob sign. Different names are there, and there is a ring of fire appearance, and it was a live fetus showing FH. So it was an unruptured live tubal ectopic pregnancy. And this is another case. She came with UPT positive and echogenic fluid in the POD. It was a ruptured ectopic hemoperitoneum. So the commonest complication of ectopic is a rupture resulting in hemoperitoneum. Different signs are there. And this is another case here in which a 40-year-old female with a recent history of abdominal surgery. She presented with abdominal pain. Here we can see a well-defined heterogeneous lesion showing air bubbles and a typical spongiform appearance. So this kind of spongiform appearance is nothing but a retained surgical sponge, which is referred to as gossipiboma. And possible complications include secondary infection. And sometimes this may be a clue. A suture material can be seen adjacent to that. This may be a clue that it could be a gossipiboma. This is another 40-year-old female presented with acute excruciating right lower abdominal pain. Here we can see that the right ovary is bulky with peripherally displaced follicles, no internal vascularity, whereas the left ovary shows normal vascularity. It is a torsed right ovary. Is there any site predilection for ovarian torsion? Yes, it is there. It is a right-sided predilection. It is because sigmoid colon on the left prevents the ovarian torsion. It is a similar case to that. It is a 26-year-old female presented with right-sided abdominal pain again. So here we can see there is a twisted ovarian pedicle. Actually, right ovary is separately seen. It is nicely enhancing, and this non-enhancing para-ovarian cyst, it is because it is just abutting the right ovary. So on administration of contrast, even the cyst wall of the para-ovarian cyst is not enhancing. So we gave it as a torsed right para-ovarian cyst with possible gangrenous changes. And the pathology report came out like this. It was a right-sided thrice twist of the para-ovarian, and the right ovary is normal, only the cyst wall is gangrenous. This is another 16-year-old female. She came with acute abdominal pain. It is a thick-walled cystic lesion which is in contiguous with the left lateral uterine wall. This is also a rare condition which is known as ACUM, accessory cavitating uterine malformation. So here the content of the cyst is blood. It is because it is hyperintense in T1, T2, and it is not suppressed in T1FS sequence. So it's a blood-filled accessory cavitating mass in contiguous with the left lateral wall of the uterus. And another important thing about ACUM is that it will be seen at the site of attachment of the round ligament on the left side. Differentials could be unicornuate uterus with obstructed horn, juvenile cystic adenomyoma, or a cystic degeneration of an uterine fibroid. But in this case, we have seen a normal uterus, normal to fallopian tubes, and a normal to ovaries. And this is another female who came for infertility workup. Here we could see two separate uterine cavities, two separate endometrial cavities. So Mullerian anomaly is suspected. So two separate endometrial cavities, either it could be a septate uterus or a bicornuate uterus or a uterine didelphys. So first we have to see the external contour of the uterus. Here the external contour of the uterus is flat and smooth. There is no dip. So biconvex uterus and uterine didelphys is ruled out. Only thing is septate uterus, and again it satisfies the criteria that The intercornual distance is less than 4 centimeter and the intercornual angle is acute. So this is a case of partial septate because the cervix is not divided. It's a case of partial septate uterus, and the closed differential could be bicornuate uterus. Commonly used systems are ASRM and H3 classifications. And the same lady came again after ovulation induction. She came with for the first trimester scan. There was she conceived in left horn, right horn appears normal, but she delivered preterm at about 28 weeks. The baby was less than 1 kg and in NICU. Case number 15. Here we can see that the first image, there is absent uterus and proximal 2/3 of the vagina with normal appearing bilateral ovaries, and there is absent kidney. So these are all come under which syndrome? MRKH syndrome, Mayer-Rokitansky-Kuster-Hauser syndrome, usually associated with renal and vertebral anomalies. This is due to arrested development of the paramesonephric ducts. This is another 19-year-old female presented with primary amenorrhea, pelvic pain and mass. Here we can see that there is echogenic fluid within the uterine cavity with blood fluid level. So the content is bright in both T1 and T2 with fluid level, and the entire uterine cavity is filled with blood. This is referred to as hematometrocolpos, usually seen in the transverse, it will be usually associated with transverse vaginal septum, imperforate hymen or vaginal atresia. This post-hysterectomy patient presented with dribbling of urine through the vagina. Here we can see that there is an abnormal fistulous communication between the left posterolateral wall of the bladder and the vagina. So this is the case of vesico-vaginal fistula. So best modality to demonstrate is the CT cystogram. This is a common case like endometrial carcinoma. So you should be very thorough in the endometrial carcinoma, ovarian carcinoma and cervical carcinoma staging. So here in this case there is a heterogeneous polypoidal endometrial lesion having more than 50% of the myometrial invasion with positive pelvic nodes. So this comes under stage 3C, FIGO staging. What is stage 4A? It is local invasion of the bladder or the bowel mucosa. This is the FIGO staging. And this PCOS, polycystic ovarian syndrome. Usually there will be lots of confusion in diagnosing PCOS. There is some criteria which is known as 2018 International Consensus Guidelines. According to this criteria, we should not call any female less than approximately less than 20 years as PCOS. It is because naturally they will have multiple follicles. So only after 8 years post menarche we can call the female as PCOS if she satisfies the criteria like more than 20 follicles per ovary and more than 10 ml volume per ovary. So criteria is same like more than 20 follicles per ovary, more than 10 ml volume per ovary, but the age should be seen like she should be more than 8 years post menarche. If exact age of the menarche is not known, then approximate age cutoff could be 20 years. This is the last case. Here we can see that this patient presented with UPT positive and it was a bulky uterus showing multiple anechoic cystic spaces giving snowstorm appearance. So this is a case of gestational trophoblastic neoplasia. This hydatiform mole can be partial or complete. We have to see is there any myometrial invasion. If it is there, then it can be invasive mole or a choriocarcinoma or a placental site trophoblastic disease. So this is a case showing choriocarcinoma. So which is the commonest site of metastasis for choriocarcinoma? Lungs. This is the FIGO staging system of choriocarcinoma. So stage 3 is lungs. Other than lungs, metastasis to any other site comes under stage 4. These are all the entire list of cases which I have explained. If you want, you can take a photograph of this. I have explained you all these. These are all the common spotters asked. Thank you all for this golden opportunity.